Hello again, everybody. This is Wendy Lokanc-Diluzio. In this presentation, I will briefly discuss strategies to prevent sexually transmitted and bloodborne infections. This is not a comprehensive overview. If you want additional information about prevention strategies, please email me and I can forward some additional information to you. So what's ahead? In this presentation, I'll provide an overview of key messages for sexually transmitted and bloodborne infection prevention. I'll discuss condoms and dental dams. I'll discuss needle exchange programs and safer injection facilities, hepatitis B and HPV vaccinations. I'll provide an example of a social marketing campaign. And finally, how television can be used as a tool for prevention. Some key messages our team uses in terms of prevention include that abstinence is the best way to prevent sexually transmitted and bloodborne infections. Sexual contact means any intimate skin-to-skin contact in the genital area. This includes touching, oral, vaginal, or anal sexual activity with partners of any sex. We also tell clients that both giving and receiving oral sex carries risk for STIs. Partners can engage in lower risk forms of sexual activity or sexual stimulation such as mutual masturbation or sensual massage. If sexually active, the best way to prevent sexually transmitted and bloodborne infections is to use condoms and or dental dams for oral, vaginal, and anal sex. It's important to limit the number of sexual partners if possible. Partners should have open and honest communication with each other about previous history of STIs as well as STI testing. If either partner has symptoms, they should not have any sexual contact. Partners should not share sex toys. If they use sex toys, they should clean between use and cover with a new condom before each use. Getting tested for STIs at least once a year when symptoms are present is important. And clients should consider getting tested every 3 to 6 months if there is a new sexual partner or if partners have other sexual partners. Accurate and consistent use of male condoms or female condoms is important to decrease the transmission of STBBIs. A male condom is a disposable latex or polyurethane sheath worn on the penis. A female condom is a disposable sheath placed inside the vagina. Both male and female condoms prevent direct contact between the genitals, preventing the exchange of bodily fluids such as semen, pre-ejaculate fluid, and vaginal secretions. Condoms help to protect against pregnancy, STIs, and bloodborne pathogens. In case you want more information about correct use, please explore the links provided in this slide. As a fun fact, I wanted to provide a brief historical perspective of condoms. Kahn and colleagues explored safer sex in ancient and modern history. They conducted a historical and medical review of condoms. The resources they examined indicated the first use of a condom was that of King Minos of Crete. Pasiphae, his wife, used a goat's bladder in the vagina so that King Minos would not be able to harm her, as his semen was said to contain scorpions and serpents that killed his previous mistresses. 2 Egyptians, condom-like glands caps were dyed in different colors to distinguish between different classes of people and to protect themselves against intestinal and urinary tract parasites. The ancient Romans used the bladders of animals to protect the women. They were worn not to prevent pregnancy, but to prevent what they called VD or venereal diseases at that time. Finally, Charles Goodyear, the inventor, utilized vulcanization, the process of transforming rubber into malleable structures to produce latex condoms. The authors of this article state or conclude by stating the greater use of condoms all over the world in the 20th and 21st centuries has been related to HIV, and that their account of the history of condoms demonstrates how a primitive idea turned into an object that is used globally. Harm reduction is a strategy targeted at groups or individuals that reduces the harms related to various behaviors that are either legal or illegal. Examples of harm reduction strategies include educating sex trade workers about male and female condoms, safer injection facilities, and needle exchange programs. Needle exchange programs and safer injection facilities acknowledge that abstinence from all drugs is not realistic for all people, and therefore, although drug use is not condoned, it is seen as essential to implement risk reduction strategies to reduce harmful outcomes related to drug use, such as HIV or hepatitis B or hepatitis C. Needle exchange programs, also called needle and syringe programs, provide injection drug users with free, sterile injecting equipment to reduce the risk of contracting and spreading infection. This harm reduction strategy is endorsed by the World Health Organization, as well as health authorities across Canada. However, this strategy is considered controversial among policymakers and the general public. Although research supports that needle exchange programs decrease HIV among injection drug users, there are concerns that they may enable or encourage injection drug use, prolong the injection drug use of their clients, and or discourage clients from seeking addiction treatment. Werb and colleagues investigated needle exchange programs in Vancouver from 1996 until 2010. During that time, the number of needle exchange programs increased from 1 to 29. Their research suggests that as the number of needle exchange programs increased, the proportion of injection drug users reporting cessation increased as well, so that is positive. Safer injection facilities provide a safe location for drug users to inject their own drugs with clean equipment under the supervision of medically trained professionals. Safer injection facilities aim to decrease the spread of infectious disease, improve contact between healthcare system and injection drug users, decrease the use of drugs in public places, decrease fatal and non-fatal drug overdoses, and increase enrollment of injection drug users into addiction treatment and rehabilitation programs. Although safer injection facilities are an innovative public health intervention, they are extremely controversial in various countries, including Canada. In 2003, healthcare providers in Vancouver piloted Insight, the first medically supervised safer injection facility in North America. Evaluation research of this program indicated several positive outcomes, including decreased syringe sharing, decreased injection-related litter, decreased numbers of individuals injecting in public, and decreased numbers of syringes discarded in public. On to vaccinations. There are vaccinations to prevent hepatitis B and HPV, as you all probably know. The widespread availability of hepatitis B vaccine has assisted in prevention of infection. Publicly funded vaccination programs are offered in all Canadian provinces and territories. Hepatitis B vaccine is routinely offered to all Canadian children and adolescents. If parents are hepatitis B carriers or they were born in an endemic area, the vaccination is offered to children during their first year of life. In 2006, Health Canada approved a vaccine, Gardasil, that protects against 4 strains of HPV. Two of the strains are responsible for approximately 70% of cervical cancer cases, whereas the other 2 strains are responsible for around 90% of genital warts cases. In 2010, a second HPV vaccine, Cervarix, was approved by Health Canada. Cervarix was designed to protect against 2 strains of HPV causing cervical cancer. It also provides some protection from 2 additional strains. Together, the 4 strains account for 80% of cervical cancer cases. Although Cervarix does not protect against genital warts, it may offer longer-term protection against HPV causing cervical cancer. In 2015, a third vaccine, Gardasil 9, was approved by Health Canada. Gardasil 9 protects against 9 HPV strains. These 9 strains cause around 80% of cervical precancers, 90% of cervical cancers, 75% of HPV-related anal, vulvar, and vaginal precancers and cancers, and more than 90% of genital warts. HPV vaccine is considered a medical milestone in terms of cancer prevention. It is anticipated that the long-term implications of the vaccine will result in a reduction of cervical cancer cases, although the need for women to have regular Pap tests will still continue. Gardasil and Gardasil 9 HPV vaccines are available for females ages 9 to 45 and males ages 9 to 26. Cervarix HPV vaccine is available for females ages 9 to 45. Currently, all Canadian provinces have publicly funded vaccination strategies in place for school-aged girls in grades 5 to 9, depending on where they reside. And the original Gardasil vaccine is used for publicly funded programs. As of 2014, only 2 provinces, Alberta and Prince Edward Island, have also implemented publicly funded vaccination program for boys. For females and males who do not qualify for the publicly funded programs but are within the recommended age group, the vaccine is available for a cost for the 3 doses. Women older than 45 and men older than 26 who are interested in HPV vaccine should be encouraged to speak to their healthcare provider. Social marketing can be defined as a program planning process that applies commercial marketing concepts and techniques to promote voluntary behavior change. In Canada, these types of campaigns are becoming more innovative as they provide blatant and at times provocative messages to different segments of the population. Unfortunately, many of these campaigns are not properly evaluated for their short or long-term impact on the target population. One Alberta STI campaign that had evaluated results was launched by Alberta Health Services in 2013. The purpose of the Sex Germs campaign was to raise awareness and provide information about STBBIs and encourage safer sexual practices among 16 to 29-year-olds. The campaign was an extension of the previous 2011 Alberta syphilis awareness campaigns called Don't You Get It and Plenty of Sif, but was expanded to include STBBIs in response to continued high infection rates in Alberta. A variety of English-only campaign materials such as posters, bar coasters, matchbook condom covers, bar stamps, washroom video boards, and television, radio, and cinema pre-roll ads, social media tools, and guerrilla tactics, which include a penis mascot in bars and on the street, captured attention and directed viewers to the www.sexgerms.com website. Campaign images featured attractive individuals displaying graphic flu-like symptoms. So, for example, a runny nose, red eyes, with the slogan, "A cold isn't the only thing you could catch." A second group of posters displayed made-up words combining sexual body parts and disease suffixes, such as vag-fluenza and dicgitis. The images and words were meant to capitalize on public awareness about flu and other germs and the need for good hygiene, creating a parallel to awareness about STI and the need for safer sexual practices. Here is what the posters looked like. There was also a Sex Germs television spot, and I've posted the link to YouTube on Moodle, so please feel free to take a look at it to see what the television spot looked like. The primary messaging of the Sex Germs campaign focused on behavior change to safer sexual practices, with the Sex Germs website providing secondary messages and resources for getting tested. The campaign was evaluated using online surveys. A total of 1,152 people completed the online surveys. Over 3/4 of the survey participants reportedly had seen or heard at least one component of the campaign. Overall, 55% of the respondents reported that seeing or hearing the campaign or visiting the Sex Germs website made them wonder a little or a lot if they might be at risk for having an STI. Of the respondents who had seen or heard at least one component of the campaign or visited the website, 73% reported that the information made them think they ought to practice safer sex. 64% indicated they expected to use safer sexual practices in the future, and 41% reported they had already practiced safer sex. On to television. Television is often seen as a negative influence on the sexual attitudes and behavior of adolescents. However, television occasionally includes messages about the risks of having sex that may have a positive effect on youth. In 2003, Collins and colleagues assessed the impact of condom efficacy messages in an episode of Friends on teens. A sample of 506 American adolescents 12 to 17 years old who had been regular viewers of Friends the previous year were surveyed by telephone shortly after the episode aired. The researchers measured viewership of the Friends episode, recall of the condom efficacy message, beliefs about condoms, self-reported change in condom knowledge, and discussions of condom efficacy with parents. In terms of the findings, 27% of the sample saw the episode, and 65% of these viewers recalled its depiction of condom failure resulting in pregnancy. 40% of the viewers watched with an adult, 10% of viewers talked to an adult about condom efficacy as a result of the show. Compared with other viewers, youth who talked with an adult were more likely to report learning about condoms from the episode. The authors concluded that entertainment television can serve as a healthy sex educator and can work in conjunction with parents to improve adolescent sexual knowledge. Thank you for listening to this presentation. Please feel free to email me if you have any questions.